So want to just switch gears a little bit, Claire, and talk about the kind of a subcategory of folks with peripheral arterial disease that we're seeing more and more. It's this concept of polyvascular disease. Um, what are your thoughts on that? Are you seeing that a fair bit as well, or and if so, do you approach these patients any differently?
Absolutely. I think that, the risk factors that we understand for PID are also risk factors for atherosclerotic disease and other vascular beds. So, your cerebrovascular disease, your coronary artery disease, all of them sort of have slightly different pathophysiology, but they all seem to have very similar risk factors. So I think this leads back to sort of the idea of the holistic approach to the patient. So understanding that somebody with PAD, especially PAD that's bad enough for them to have symptoms, probably has some degree of vascular disease in other beds, and it would be sort of incomplete to not assess them for these other risk factors. So, when you're assessing somebody for their functional status to determine, what their goals are and what you might expect to restore as far as their function for PAD, you also have to consider if some of their limitations could be due to, coronary disease that hasn't been addressed. And certainly any major intervention you do on the leg in the setting of coronary disease that hasn't been addressed can put them at, sort of extraordinary risk. So, you have to kind of approach these patients knowing that they are at high risk for multiple different issues. And then, education, I think, becomes incredibly important as well, so that they understand that some of the things you're doing for them are not just for their leg. They are also for, prevention of strokes, prevention of heart attacks. I think sometimes that helps to put these things into context for patients and really drive home the need to be a partner in the care, in their care of their peripheral artery disease.
Yeah, no, those are all great points. I totally agree with you. For me, it highlights, um, you know, really where we are in kind of the investigative or the kind of academic pursuit of our understanding of these different disease substates. So, over the course of the 20 years that I've been in practice, really we've approached these in a very siloed fashion. So, our cardiology colleagues looked at the heart, we looked at the legs and the neck, but we didn't really have discussions about the intersection between the three. And I think that's changing. I think um, our cardiology and cardiovascular colleagues have really woken up to the burden of peripheral arterial disease, and the American Heart Association has put out kind of a call to arm and directives to kind of focus on peripheral arterial disease in a real way. And we're all starting to realize the overlap in terms of the medical care. And I think some of the more challenging aspects of the care of these patients are balancing kind of what antiplatelet agents they should be on, what lipid lowering or cholesterol lowering agents they should be on, and what antithrombotics they should be on. It can be very complicated. When I was starting out, there was sort of aspirin. Everyone was on it. Over time, obviously, the use of Plavix became very prevalent after any coronary intervention or any endovascular lower extremity intervention. And now with, I'm going to show you the slides, or I'm going to show you the results of that evolocumab, which is a PCSK9 inhibitor, and that is very effective at driving down the LDL-C to dramatically low levels, as low as 30. And as a result of that, there was an astonishing kind of drop in the major adverse cardiac events, or MI, stroke, and death, but also this concept called MAIL, a major adverse limb event, lower amputation rate, lower return to the operating room for urgent revascularization, and acute limb ischemia. So that's kind of one category of medications. And then the COMPASS trial, followed by the Voyager trial, both looked at rivaroxaban, the kind of DOAC, Xarelto, and the same thing, just a dramatic improvement in both MACE and male. And so it highlights the question about, gee, should all of our PAD patients be on Xarelto or rivaroxaban? If so, should it just be aspirin, which is what the trials showed, aspirin plus 2.5 milligrams twice a day of rivaroxaban? Or should it be Plavix and Xarelto? A complicated kind of choice now that it's a good thing, but I do find myself having lots of conversations with my vascular medicine and cardiology colleagues about optimal management. What do you think about that kind of medical choice, and maybe say a word about your thoughts on statins as well for this complicated group of patients?
Yeah, I think this is, as you said, there's more and more data coming out that aspirin alone probably isn't the most ideal. But of course, you're balancing a lot of risk factors, because certainly people with PAD, are they steady enough on their feet to have multiple, thrombotic agents at the same time? Are you putting them at risk for bleeding? And I think every choice has to be sort of individually fitted to the patient, but certainly the data is very compelling that probably two agents of some sort is the way to go. And I think over time we're going to figure out really what's more ideal as far as balancing the PAD outcomes and the CAD outcomes, because I think you don't have as much data in the PAD world as you do in the coronary world to support one regimen over another. I certainly, in patients that don't have active issues with their coronaries at the time, tend towards following the Voyager trial, using that low dose of rivaroxaban in addition to an antiplatelet agent. But I also try to approach these things in a very multidisciplinary mindset when I do have someone who has active disease in other beds, because I would like to hear what the cardiologists think their risk profile really is before I make a decision that's driven more by a PAD-centered outcome versus both, and vice versa. So certainly a complicated issue, and one that hopefully I will feel comfortable with as more data comes out over the years.
Yeah, no, I think that all highlights, you mentioned it earlier, but I think our patients really benefit from a multidisciplinary approach if they have diabetes, and almost 70% of our patients in this category do.
Right.
Making sure there's a diabetologist or an endocrinologist in the mix, or their primary care doctor or cardiologist is really on top of their glucose management. Certainly all the efforts to stop smoking, which can be very challenging, but using good medical therapy to help do that is important. We talked about statins. I think pretty much every PAD patient of ours should be on either 40 milligrams of Crestor or 80 milligrams of Lipitor, if not absolutely additional agents, as we talked about. Good blood pressure control, and then a good discussion with the rest of the team on what's the best antiplatelet and antithrombotic regimen. I think all of that is kind of front and center. And again, as you referenced, a thoughtful discussion between the different providers. And we're vascular surgeons. We most of us do both endovascular and open surgery, but our interventional radiology and interventional cardiology colleagues do endovascular, and it's sort of important for them to pair up with a surgeon and just have a good discussion. Because the real take home is complicated patients. We really need to do an individual, tailor the care, given the complexity to the individual patient, and working with them to see what they want, and ultimately help relieve their pain, and if things work out, salvage the limb and get them back on their feet. Right. So any sort of final thoughts on on everything we've talked about. I feel like we could talk for hours on
For
this
hours, I'm
complicated
sure.
topic, but
One of the things I've noticed with statins in particular that, that I try to sort of educate patients and anyone I encounter on is that, patients will say, well, my lipid panel looked fine. They told me I didn't need anything for it. But really, there's a multiple different ways that statins are really impacting the progression of their disease. And so even patients who have, LDL levels that, aren't particularly elevated probably will still benefit from the statins. And that's a little bit of an education process as I convince people, this is your panel looks okay, but there's still a good reason to be on them and to continue taking them, beyond simply like getting the number to a certain number. I think some of the um, uh, sort of things that they have been told in the past become less true when we are dealing with sort of active PAD, symptomatic PAD. We know it really does make a difference, even if you had relatively well controlled lipid levels beforehand.
well, you're going to think I'm making this up, and I was sort of laughing as you were talking because I literally had that exact discussion about an hour ago. I came right from clinic, and I had an 80-year-old patient who I met at the time of her heart surgery, and she is on, at the time that she had her heart event, she got bumped up to a high dose Lipitor, and she was asking me, now that my heart's fixed, can I come down on it?
Right.
I've heard, all sorts of tales of woe with statins, and I could luckily use the fact that she had, moderate carotid stenosis to give her the same lecture that you just kind of alluded to, and it was effective. She thankfully kind of got the message, but